class, which is quite important because you get most of the time short notes in your exam from this topic. And second thing is it is often kept in your clinical exams also because it is relatively pain-free condition and a young child who can be examined very easily. So I will be covering three topics today. One is Baumann's angle, second is cubitus varus, third is cubitus valgus. So with this introduction, let us start the class for today. I have a 10-year-old patient today. So we have a 10-year-old boy who had history of elbow, which was around 3 years back. So it's a late complication, whatever he is having, because it happened after it is the long story, and long back he had the fracture. So patient developed deformity and he has occasional pain over the elbow. There is no other associated complaints. So the main complaint here is patient is having history of injury, which is little old, that is 3 years back, and there is deformity around the elbow. So if you see here, this is the deformity around the elbow. So the main complaint here is deformity, and there is a history of fracture of the elbow. So it is a delayed complication after the fracture. So what is the delayed complication after the fracture, which is relatively pain-free? It is malunion. So this is a case of malunion following supracondylar humerus fracture. So this is one of the commonest complications which we come across after the supracondylar fracture, managed by traditional bone setter, or somebody have mismanaged it or couldn't reduce it properly. So this is a post-traumatic elbow deformity, which is a delayed complication. So before knowing what is cubitus varus or cubitus valgus, let us know what is the normal around the elbow joint. So how is the elbow joint? Elbow joint, we have a normal carrying angle. What is that carrying angle? Outer angle between the long arm of the arm. Long arm, if you see the long axis of the arm and the long axis of the forearm, they form the angle. They are not straight, they are outward directed. So it ranges, different books give different rates. So 5 to 15 is the 15 degree is the range of cubitus varus. It is little more in female, relatively less in male. So this outward angulation from the long axis of the humerus is called as cubitus varus. So there is no standard value for it, which we can use it for all the patients. So the best way to measure it or compare it is to compare with the normal side of the patient, so which is not affected. So if you see here, this is a normal long axis of the humerus, this is long axis of the forearm. So this angle form is your 5 to 15 degree outward angle, which we call it as cubitus varus, which we call it as normal carrying angle. Here, if you see, what is happening is this angle is getting directed inside. So it is decreasing or going towards the negative side. So this is cubitus varus. So the limb is deviated towards the midline or towards the body is cubitus varus. It is going away from the body is cubitus valgus. So these two conditions are equally important because we have as we know, the elbow injuries are the third common injury in the pediatric. So they likely to land up in delayed complication or malunion, so resulting in either cubitus varus or cubitus valgus. So before starting how to measure the cubitus varus or main topic of cubitus varus, we need to know about the Baumann's angle. This angle is, you did not know everything about it, but it was asked in your entrance examination many times. So how will you measure the Baumann's angle? So Baumann's angle, if you measure, this is your humerus, distal end of the humerus, and this is the physis of your capitulum. Okay, this is your ulna and the radius. So you draw a line along the long axis of the humerus like this, and draw a line along the distal capitulum physis. So this angle form is called as Baumann's angle. So it is around 70 degree. So it is also a range you can take 65 to 80 degree as normal, because different authors and different books describe it differently. And the best way of measuring in any patient is compared with the Baumann's angle of the non-affected side. So if you simplify this angle or presentation here, you see here, this is the humerus. and this is your capitular physis. So you draw a line along the long axis of the humerus like this and the line along the physis like this. This angle form is your Bowman's angle. So we'll take it as 75 degree. So if what happens is in cubitus varus, the limb will deviate like this. So this will move outside and result in increase in the Bowman's angle. If you see here, this is the cubitus varus. So this angle increased. Whereas in cubitus valgus, the limb move away from the midline. So cubitus varus, the angle will decrease. Cubitus valgus angle will decrease. So these two things you need to remember. So Bowman's angle, long axis of the humerus and the capitulum physis, this angle is around 75 degrees, and best way is to compare with the normal side. Second thing is in cubitus varus, the angle increases, in cubitus valgus, angle decreases. So this is to estimate the amount of radiological deformity. So radiological, how much is radiological varus or valgus, we can compare with the normal side. So we'll go to cubitus varus. Cubitus varus is otherwise called as gun stock deformity. Why it is called as gun stock deformity? If you see this, the left side is the normal side, then the right side is the deformed side. If you see on the deformed side, instead of this limb going like this, it got deviated. So this give appearance of gun stock. So that's the reason it is called as gun stock deformity. It is very commonly asked question, which deformity is gun stock deformity? It's a cubitus varus deformity. And what is the fracture will result in gun stock deformity? It is malunited supracondylar humerus fracture. So what is happening is, as I told, it is varus, so there is decrease in the carrying angle due to deformity at the elbow joint. So etiology is most of the time trauma following malunited supracondylar fracture. This point is very important. Then other causes are epiphyseal dysplasia, and there are many more causes, but for your level, for undergrad level, the common cause is malunited supracondylar humerus fracture in varus malunion. So what are the clinical findings in cubitus varus? So patient will have history of fracture, long history of fracture, maybe like 2 years, 3 years around the elbow, which was managed either by the quads or managed by someone who, due to some reason, they couldn't achieve the proper reduction. So patient will have deformity, and sometimes now if patient is coming very late with more deformity, patient will have some ulnar nerve deficit because patient may have tardy ulnar nerve palsy. We get tardy ulnar nerve palsy in both cubitus varus and cubitus valgus. But the reason for the tardy ulnar palsy is little different, or mechanism of patient developing tardy ulnar palsy is different in both. So we'll go through that. Then patient will have sometimes, due to this varus deformity, they should need to move the shoulder more. So they may have sometimes shoulder pain, elbow pain, and the posterior triangle of the elbow is tilted. And we can measure the deformity by using a goniometer. So we'll see next slide. Here, if you see, this is the posterior triangle of the elbow. This is the medial side. So it's a medial epicondyle. This is the lateral epicondyle, and this is the olecranon. So if you see here, this is the tip of the medial epicondyle, this is the lateral epicondyle, and this is olecranon. So they form a triangle. This triangle, all sides are unequal. So it is a scalene triangle. All triangular sides are unequal. So what happens is the fracture is occurring above the triangle, and after the fracture, what is happening is it is changing its position. So it's going into varus. So there is the dimension of the triangles will not change. Only the orientation or angulation of the triangle changes. So this is how you measure the posterior triangle dimension and compare it with the normal side. So in the supracondylar elbow, supracondylar malunited elbow fracture or cubitus varus will have just tilting of the triangle. This point is also very important. We have only tilting of the triangle, but there is no change in the dimension. Why? Because the fracture is happening above the triangle. So it's not involving the dimension of the triangle. It is happening above the triangle. And this triangle is all sides are unequal. So it is scalene triangle. And this is how you measure with the goniometer. Keep one limb of the goniometer along the humerus or arm and one along the forearm. So angle will measure, and how much is the deviation we can measure by goniometer. Then I told you there is a tardy ulnar nerve palsy in cubitus varus. Tardy is slow. Tardy ulnar nerve palsy. What is happening is this is your ulnar nerve coming behind the triceps, and going, this is your groove of the ulnar nerve, and it is again entering into the forearm. So this area is very important where the ulnar nerve comes out. So after the fracture malunion, the size of this area decreases. So there will be continuous compression over the ulnar nerve whenever patient moves the elbow. So tardy ulnar nerve, this continuous compression over the period of time results in ulnar nerve palsy. So what is the mechanism here for the tardy ulnar nerve palsy in the patient who is having malunited supracondylar fracture, or patient who have this cubitus varus? It's a compression neuropathy, compression type of neuropathy. So it's a due to the decrease in the space, the patient will develop tardy ulnar nerve palsy. So it is called as compression neuropathy, which is present in malunited supracondylar humerus fracture. So how will you diagnose? As I told, you need to take the X-ray, measure the Baumann's angle, measure the ulnohumeral angle. So you have a deviation in ulnohumeral angle, you have increased the Baumann's angle. What is the treatment for supracondylar humerus fracture? So supracondylar fracture humerus is malunited. So it's a deformity. We need to go for correction, corrective osteotomy. So who described it is French osteotomy. French is the person who described this osteotomy. So it goes by name French osteotomy. There are many modifications, but for undergraduate level, if you know the French osteotomy, that is more than enough. So if you see, this is your humerus, humeral line, there is a varus angulation, varus here. So this is the body of the patient. So patient is having varus deformity. So what we are doing is we are removing the wedge of the bone, that is from the base of the wedge is over the lateral side, lateral based. And what we are doing is after taking out wedge, see. So we are taking out this wedge. So after the wedge, how will be this one? There is a space here. So what we are doing is we are closing this space. So this is called as closed wedge osteotomy. And the base of the wedge is over the lateral side. So lateral based closed wedge. Lateral base closed wedge osteotomy. So this is what we do in patients who have malunited supracondylar fracture humerus. So what is the name of this osteotomy? This osteotomy is a French osteotomy. So lateral base closed wedge osteotomy is French osteotomy. This is again same. This is my own patient here. If you see patient is having varus deformity, we have done lateral base wedge removal, and patient is having correction of the axis of the forearm or elbow. So this is all about cubitus varus. Then we'll move on to the next topic, that is cubitus valgus. What is cubitus valgus? It's an opposite of cubitus varus deformity. Here what is happening, carrying angle is increasing and there is deformity at the elbow joint. Here the etiology is again the fracture around the elbow, but it is not the supracondylar humerus fracture, it is lateral condyle fracture. So it may land up in non-union or it may land up in avascularity, resulting in valgus deformity. Sometimes radial head fracture also result in cubitus valgus, and facial dysplasia, they may result in cubitus varus or valgus. So out of this all etiological factor, you need to remember there is a lateral condyle fracture of the distal humerus, which results in either non-union or avascular necrosis, resulting in cubitus valgus. Here, if you see, this is a diagram here. Patient has the lateral condyle fracture here. Then along with the radial head, this movement has moved outwards, resulting in angulation outward. So this is how the cubitus valgus results. So what are the clinical findings? Patient will have history of trauma, deformity, which is progressively increasing. Sometimes they have pain, and here it's more common, tardy ulnar nerve palsy when compared to the supracondylar humerus fracture. So how will you diagnose? Again, the diagnosis is clinically we measure by goniometer and by clinical triangular measurement. Here, if you see the triangle, the dimension of the triangles will change. As I told, medial epicondyle, medial epicondyle, lateral epicondyle, and olecranon. So what is happening is this condyle is moving outwards. So this triangle, there will be increase in the dimension or base of the triangle. Base of triangle is increase. So this is how you can differentiate supracondylar fracture from uh, malunited supracondylar fracture from malunited or non-unilateral condyle fracture on clinical examination. Again, treatment here is you need to go for corrective osteotomy. So, and we need to go for fixation of the fracture if you want. And here, one more thing is you need to go for anterior transposition of ulnar nerves. So, I just want to tell you how the ulnar nerve palsy develop here. If you see, this is a normal limb with the humerus here. This is ulnar, this is radius on the medial side. So, this is a normal thickness of the ulnar nerve. What happens is this: the patient has deviation outside. So if you see here, the patient is having outward deviation of the elbow. So here, if you see here, we have a cubitus valgus. So what is happening in cubitus valgus is there is a stretching over the nerve. So this stretching over the nerve causes pressure on neuropraxia. So it is called as traction neuropathy. Traction neuropathy, which is resulting in ulnar nerve palsy in cubitus valgus. If you see here, this is the patient who is having cubitus valgus. The ulnar nerve is behind the medial epicondyle and it is getting stretched, and patient is having deformity. So what we'll do is we'll again here do we do corrective osteotomy. So it goes by name Milch osteotomy. If you can remember this name, well and good, otherwise no need. So what we are doing is we are cutting the bone here and we are realigning here. And in addition to this, we'll go for transposition of the ulnar nerve. So ulnar nerve lies posterior to the medial epicondyle. We are transferring that nerve from the posterior aspect of the epicondyle to anterior. So this is called as anterior transposition of the ulnar nerve. So here, just to repeat, how we treat lateral epicondyle or malunited lateral epicondyle or cubitus valgus deformity, we do corrective osteotomy, which is otherwise called as Milch osteotomy, and we are transporting the transposition ulnar. We are changing the direction of the root of the ulnar nerve and transposing it anterior to the lateral epicondyle. This is all about today's topic. We'll just have a quick revision between the cubitus varus and cubitus valgus. So we have elbow deformities. So it may be cubitus varus, or it may be cubitus valgus. So cubitus varus is inward, so towards midline. Here it is away from a midline. So what is happening to carrying angle? Carrying angle here, it is decreasing or it is becoming negative. Here carrying angle is increasing. What happens to Baumann's angle? Baumann's angle is increasing. Here it is decreasing. Then what happens to the posterior triangle? Posterior triangle, only there is tilt. Dimension, same. Here what is happening? There is some tilt plus change in the base. Then over here we have ulnar nerve palsy in both. Here it is compression neuropathy. This point is very important. Compression. Here traction. So here there is a traction over the ulnar nerve. Here is a compression over the ulnar nerve. How will you treat? French osteotomy, Milch osteotomy. And here we do one additional procedure, that is anterior transposition of ulnar nerve. If you see here, this valgus and this yellow one is an ulnar nerve. So here you can see ulnar nerve is lying behind the medial epicondyle. What we have done is, after correcting it, the ulnar nerve, we have transposed it anteriorly. So it is called as transposition of ulnar nerve. So here we have done a lateral based close wedge osteotomy. Lateral based close wedge osteotomy. So this slide is very important. Lot of questions will come in your exam. So please go through it again and again till your doubt get clear. Okay. Then